The Healthcare System, Lecture 1, Some Fundamentals, Conceptual Models, and Important Questions. Welcome to this first online lecture. Some students have found that the best way to use these lectures is to print out the handouts, listen to the lecture once all the way through, and then listen again while writing notes on the handouts. If you are watching this on YouTube, you might want to pause to download the handouts first so that you can take notes. Some of the lectures will follow the text closely with additional information, but some will be supplementary to the text readings for that week. So it's really important to keep up with the readings also. One thing that I like about this text by Xian Xing is that it has a nice section at the end of each chapter for the jargon, also known as vocabulary, and it has review questions. If you go through these carefully, you will definitely be ready not only for the quizzes, but to carry on a professional conversation without sounding like an outsider to healthcare. This is useful in so many ways. More on that later. This first lecture focuses on the big picture. There are a couple of additional YouTube videos that are part of the lecture, and both capture the essence of the healthcare system and the Affordable Care Act very succinctly, one with a little bit more humor than the other. And these are the learning objectives for this lecture. Each week has a set of learning objectives that give you an idea of what the important takeaway ideas are. I have to say that the ones for this week are very important to get under your belt or in your memory banks early. They are all concepts that we will be expanding on throughout the semester. The cost-quality access dilemma is also referred to as the iron triangle or the unsolvable problem. The quad function model of healthcare is something that is specific to Xian Xing. It's the model that they use to kind of organize the text around. And then the external forces impacting on healthcare. We'll talk a little bit in depth about external things that you don't typically associate with healthcare, but that definitely have an impact. And then we'll talk about some other models of healthcare delivery from other countries. This diagram represents the so-called eternal triangle or three-legged stool that describes the dilemma of the healthcare system in this country today. You need all three sides to complete the triangle, all three legs to hold up a stool. The trick is determining how to improve one of the three without damaging the other two. We will spend a lot of time this semester learning how this juggling act has been done so far. We may even come up with some ideas to help make it work better. Costs. Healthcare spending currently accounts for around 18% of our gross domestic product. That's a number that you really need to remember. The Centers for Medicare and Medicaid, or CMS, studies estimate that it may rise to as much as 20% by the year 2020. Many experts foresee a train wreck down the track when costs get this high. As costs increase, employers have begun to pass on the increases to employees, called cost shifting. Because the system is so large and interdependent, a rise in costs in one area affects others in seemingly unrelated areas. For instance, the market pricing of newly patented prescription drugs results in higher costs to both consumers and to the federal government, who must reimburse prescription of drugs under Medicare Part D and Medicaid. Development of new technology creates rising costs for providers, both inpatient and outpatient, and also nursing homes and other long-term care facilities. And through cost shifting, this goes to the consumers who bear part of the burden. Your text refers to the concept of provider-induced demand, which is referred to in regular economics as supplier-induced demand. The text defines this in a somewhat biased manner, in my opinion, and you'll have to check the definition to see what I mean. But marketing and prescribing the latest medication or medical procedures can increase patient demand for services. There's another term that we'll come across later in this semester called the technological imperative. The idea that once new technologies such as MRIs, PET scans, non-invasive colonoscopies, and so on come on the market, we all want the latest and the best, also driving costs up. So it works both ways. This could result from either say I go to my primary care physician and I want an MRI and I ask for an MRI, that is the technological imperative. However, if my primary care physician buys all of this new technology and then prescribes it for patients indiscriminately in order to drive up demand, then that is provider-induced demand. It works both ways. And one of the ways to see how this differs geographically is go to the Atlas of Healthcare, Dartmouth Atlas of Healthcare, which shows the geographical distribution of things such as facilities using MRIs, facilities prescribing medication for ADHD, and you can see that in some even different census blocks there are higher rates of prescriptions of different kinds of technologies. And of course, with higher rates of prescriptions or use of these procedures, the costs are going to be driven up. So some of it is dependent on providers. Quality. Just what is healthcare quality? You might be surprised to know that no one single definition of healthcare quality exists. During the last 15 years, researchers, regulatory agencies, consumers, the federal government, and insurance companies have all begun to demand accountability for results. We will learn what all of these entities are doing to capture the concept of quality and concrete measures that can be compared between hospitals, healthcare organizations, between insurance plans, and over time, to name a few comparisons. We will learn about the move to reduce medical error, issues with information technology, and interconnectivity. Access. You will see in Chapter 1 that the most accurate measure of access to health care is your insurance status, not necessarily your income. But access is so essential that the Healthy People 2020 initiative for the United States includes access to health care as one of the top 10 indicators of the health of a population. Access varies by income, race, age, geographical location, and educational level, among other factors. Elimination of these disparities in access to care is a major goal for Healthy People 2020, which you will learn more about in Chapter 2 of your text. And it's also one of the major reasons for the development of the Affordable Care Act. I want to talk for a minute about the definition of a conceptual model. In this course, I'm going to use the term conceptual model. I'm going to define it as a framework for looking at complex issues that allows us to organize our thinking into categories of the whole. This iron triangle is one way of organizing our thoughts and questions. Another way is the quad function model that's included in the next mini lecture. The quad function model of healthcare delivery. It includes financing, payment, insurance, and delivery. This is another important concept that we will revisit over and over again. It's diagrammed on the next slide and on page 6 in your textbook. This model is important to learn. You'll find information about it throughout the text, and we will discuss it many times throughout the semester. The question that I would ask now for you to think about throughout the semester is whether managed care has become a fifth component of the model. And here's the quad function model, the diagram from your textbook. As the authors note, these functions do overlap. The function of managed care is to integrate the other four functions and to help them run smoothly and efficiently, an attempt to improve quality and access and decrease costs at the same time. We'll have plenty of discussion about whether this has worked out or not and what components of the Affordable Care Act, given that it is fully implemented, will provide this function for the future. The finance function. The financing function is different than the payment function. Those who finance health care are those who provide the actual money to pay for it, the source of the money that will be paid. Employers are not required to finance health care in this country, but many do. About 60% of the non-elderly population have employment-based health insurance. This number is decreasing as employers face rising costs for insurance. The federal government spends approximately 12 to 14% of its total budget on Medicare and around 7 to 9% on Medicaid. Medicaid is partially paid by states, with richer states paying a higher percentage than poorer states. The government also funds a number of other programs such as the Children's Health Insurance Plans, immunizations, and other public health services. This is all part of the finance function of financing health care in this country. A small percentage, approximately 5% of individuals, are covered by private insurance. An even smaller number pay out of pocket for medical expenses. And healthcare organizations do the financing. This is something that's not often described overtly. However, in essence, hospitals and outpatient clinics finance the portion of healthcare that they write off as uncollectible debt. So they are the invisible financiers for much of indigent care, although they do pass the costs on to their consumers. The payment function. While employers provide the money through the financing function, insurance companies and others perform the payment function. Third-party intermediaries such as EDS in Arkansas often process the payments for insurance companies. The government both finances and provides payment for Medicare and Medicaid services, although today they are often privatizing the payment function so that they may provide the financing, but a third-party intermediary provides the payment. The insurance function. Although insurance companies may perform all three functions, the term insurance refers to the assumption of risk by the insurer in exchange for periodic premiums paid by the insured. It works like this. Individually, the probability that any one of us will incur medical expense for a catastrophic accident, for example, is very small. However, we all pay premiums to share our portion of the risk with others. Pooling our resources protects us against the risk of catastrophic events. Insurers underwrite risk. They evaluate, classify, rate, and give monetary value to risks of all kinds. This is how they know what premiums to charge for what size of population. The delivery function. In the last 30 years, a plethora of new professions have appeared in healthcare delivery. New jobs for physician assistants, pharmacy aides, sports physiotherapists, and certified nursing assistants have been some of the fastest growing careers in the country, according to the U.S. Department of Labor. The landscape of delivery has become almost unrecognizable from what it was in the early 20th century. We have tertiary care hospitals with the latest in technology, outpatient or ambulatory centers where many surgeries can be done without an overnight stay, and mobile dialysis units, to name a few. Managed care. There is no single model of managed care. There are many permutations. What is essential to all of these is the combination of insurance, payment, delivery, and financing functions under one integrated approach in one organization. Prior to 1983, providers charged patients on a cost-plus basis called FFS, or fee for service, with virtually no regulation. Insurance companies reimbursed whatever the providers charged. Beginning with Medicare in 1983 and continued by managed care, payment is now determined by the type of procedure, with capitated or limited reimbursement for each procedure. This limited reimbursement was instituted to cut costs and control spiraling healthcare spending. Managed care also attempted to improve the quality of care by holding providers accountable and providing preventive care.
Under managed care, the primary care physician acts as a gatekeeper to the specialists, thus cutting down costs by controlling access. Some might say that managed care attempted to maximize all three areas of cost, access, and quality, but was unable to succeed due to the competing priorities. And beyond managed care, because managed care does not seem to have been successful in balancing the cost, quality, access triangle, other ideas are being floated about what comes next for the U.S. healthcare system. Consumer-driven healthcare, or CDHC, models are an attempt to put choice back in the hands of consumers. They differ from managed care in that consumers can pick and choose from a variety of different plans depending on their individual needs. Theoretically, it will cause providers to compete for consumers on the basis of price, quality, and convenience, driving costs down. Medical savings accounts substitute individual tax-free savings accounts for insurance. They are a form of consumer-driven health care. Universal coverage models, similar to Canada's, would provide health care to every American regardless of their ability to pay. There are controversies with these approaches. Most notably, CDHC proponents believe that universal coverage models will dilute quality, increase waiting times, and stifle competition in new technologies. Universal coverage advocates believe that healthcare is a right, not a privilege, and that CDHC models will force many Americans to choose between healthcare and other basic necessities. And finally, the Patient Protection and Affordable Care Act of 2010. Rather than launch into a full explanation of the new law, I have posted 2 YouTube videos and 1 website for your enjoyment. Well, okay, the last one's more of a resource than for your enjoyment, but it is a valuable one with a nice timeline for when all of the provisions are set to take effect. The first video is about 3 minutes long, the second one is about 9 minutes long, and is from the Kaiser Family Foundation, an important health policy think tank. I would love to hear your feedback on these videos.
If you're watching this lecture on YouTube, I don't think you can get to these links from here. You'll need to go back to the class website where they are both posted, and then resume with part 2 of the lecture.